Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. Our lecture today is very important. It's about endometriosis guidelines according to the European Society of Human Reproduction and Embryology 2022. So what are the objectives? To know about the diagnosis of endometriosis according to the guidelines and the treatment of endometriosis associated pain and the treatment of endometriosis associated infertility. What is the impact of endometriosis on pregnancy and the pregnancy outcome according to the guidelines? What about the endometriosis recurrence? What about endometriosis and the adolescence and the endometriosis and the menopause? What about the extrapelvic endometriosis and asymptomatic endometriosis? What is the primary prevention of endometriosis? And lastly, what is the relation between endometriosis and the cancer? All of these, according to the guidelines published in 2022 by the European Society of Human Reproduction and Embryology. Let us start with the diagnosis of endometriosis. Clinicians should consider the diagnosis of endometriosis in individual presenting with the following cyclic or non-cyclic signs and symptoms. Like what? Like dysmenorrhea, deep dyspareunia, dyschezia, dysuria, painful rectal bleeding or hematuria, shoulder tip pain, catamenial pneumothorax, cyclic cough, hemoptysis, chest pain, cyclical scar swelling and pain, fatigue, and infertility. And you should notice any problem or symptoms, you find these symptoms occur especially during menstruation. You should suspect endometriosis. Like if there is scar nodule and it increases in size, it becomes more painful during menstrual period. Every cycle like that, you should suspect endometriosis. Also, chest pain, cough, hemoptysis during the menstrual flow. Every month, you should suspect endometriosis, and so on. Okay? According to the system affected. However, pelvic endometriosis is commoner than extrapelvic endometriosis, and the commonest symptoms is dysmenorrhea, chronic pelvic pain, dyspareunia, and the infertility, of course. Okay, let us go to the clinical examination. We can do vaginal examination when appropriate to identify deep nodules or endometriomas in patients with suspected endometriosis, although the diagnostic accuracy is low. So we are going to do this maneuver, but the diagnostic accuracy is low and you should confirm with imaging. So go to the next step for diagnosis of endometriosis by doing either ultrasound and MRI to diagnose endometriosis. Okay. There is biomarker? Yes, there is biomarkers, but it is not recommended to ask for this biomarker. This is for research only. So there is strong recommendation not using measurement of biomarkers in endometrial tissue, blood, menstrual, or uterine fluids to diagnose endometriosis. Okay. Again, in endometriosis, as I said before, ultrasound and MRI is important for diagnosis, especially for the blind spot which cannot be seen by laparoscopy, like deep endometriosis, rectovaginal space endometriosis, retroperitoneal endometriosis. Okay? but they need to be aware that negative finding doesn't exclude endometriosis. Why? Because sometimes there is superficial peritoneal disease cannot be diagnosed by ultrasound or MRI, only seen by laparoscopy. Okay? So, yes, ultrasound and MRI is important, but negative finding doesn't exclude endometriosis. Okay, follow-up and psychological support should be considered in women confirmed endometriosis, particularly deep and ovarian endometriosis, although there is currently no evidence of benefit of regular long-term monitoring for early detection of recurrence, complications, or malignancy. Okay, according to the GDG, there is a recommendation that laparoscopic identification of endometriotic lesion is confirmed by histology, although negative histology doesn't entirely rule out the disease. So when you are doing laparoscopy and you find lesions suspecting endometriosis, you should take a biopsy for histopathological evaluation to confirm endometriosis. However, negative histology doesn't entirely rule out the disease. Okay, let us see this surprise. We said for many years that laparoscopy is the gold standard for diagnosis of endometriosis. However, in these recent guidelines, found that post-diagnostic laparoscopy and the imaging combined with empirical treatment like hormonal contraceptive or progesterone can be considered in women suspected of endometriosis. And there is no evidence of superiority of either approach, and the pros and the cons should be discussed with the patient. Okay? And this is GDG statement. GDG is abbreviation of what? Guideline Development Group. Okay? Okay. So there is no superiority between laparoscopy alone and imaging with combined with hormonal treatment. Okay? Each one has its advantage and disadvantage. Okay. In patients with negative imaging results or where empirical treatment was unsuccessful or inappropriate, the GDG recommends that clinician consider offering laparoscopy for the diagnosis and treatment of suspected endometriosis, and this is good practice point. GPP means good practice point. Okay. The appropriate frequency and the type of follow-up or monitoring is unknown and should be individualized based on what? In previous and recurrent treatment and the severity of the disease and symptoms. And this is a good practice point. Okay. Although no adequate studies exist to support the benefit of early versus late diagnosis, the GDG recommends that in symptomatic women, attempt should be made to relieve symptoms either by empirical treatment or after diagnosis of or after diagnosis of endometriosis. Okay, let us go to the treatment of endometriosis associated pain. Let us start with the analgesics. Women can be offered non-steroidal anti-inflammatory drug or other analgesic, either alone or in combination with other treatment to reduce endometriosis-associated pain. What about hormonal treatment? It is recommended to offer women hormone treatment like what? Like combined hormonal contraceptive, like progesterone, like the Unigest 2 milligram tablet every day, like GnRH agonist, like GnRH antagonist. All of this as one of the options to reduce endometriosis associated pain. And this is strong recommendation. Again, The GDG recommends that clinician take a shared decision-making approach and take individual preference, side effects, individual efficacy, costs, and availability into consideration when choosing the hormone treatment for endometriosis-associated pain. And this is a good practice point. Okay, what about combined hormonal contraceptive? Women suffering from endometriosis-associated dysmenorrhea can be offered the continuous use of combined COC pill. It is recommended to prescribe women a combined hormonal contraceptive, oral or vaginal ring like Nova ring or transdermal implant like Implanon to reduce endometriosis-associated dyspareunia, dysmenorrhea, and the non-menstrual pain. And this is a strong recommendation. What about progestogen? It is recommended to prescribe women progestogen to reduce endometriosis-associated pain. The GDG recommend that clinicians make the different side effect profiles of progestogen into account when prescribing them. And you should tell your patient about the side effects of method of treatment, okay? It is recommended to prescribe women levonorgestrel releasing intrauterine system like Mirena or an etonogestrel releasing subdermal implant like Implanon to reduce endometriosis associated pain. What about GnRH agonists? It is recommended to prescribe women GnRH agonists to reduce endometriosis associated pain, although evidence is limited regarding dosage or duration of treatment. Okay, the GDG recommend that GnRH agonists are prescribed as a second line, not the first line. For example, if hormonal contraceptive or progestogen have been ineffective due to their side effect profile. So don't start with the GnRH agonist, start with hormonal treatment, for example. But if this hormonal treatment like COC is ineffective, you can shift to second line, which is GnRH agonist. Why I make it second line? Because the side effect profile, like osteoporosis and the other symptoms of menopause-like state. Okay? Clinicians should consider prescribing combined hormonal add-back therapy alongside GnRH agonist therapy to prevent bone loss and hypoestrogenic symptoms. So to avoid the side effect of GnRH agonist, you can add combined hormonal add-back therapy, okay, like COC. Okay, it can be considered to prescribe women GnRH antagonist. We shifted now to GnRH antagonist, okay? It can be considered to prescribe women GnRH antagonist to reduce endometriosis-associated pain, although evidence is limited regarding dosage or duration of treatment. Again, in GnRH antagonist, the GDG recommend that GnRH antagonists are prescribed as a second line, the same as I said in GnRH agonist. We are using this as a second line. Why we recommend as a second line? Because it has a side effect profile. Okay, so I'll keep it if the patient not responding to COC treatment or progestogen medical treatment. So second line treatment could be GnRH antagonist. What about aromatase inhibitor? In women with endometriosis associated pain refractory to other medical or surgical treatment, it is recommended to prescribe aromatase inhibitor. So if your patient is not responding to medical or surgical treatment, try to start, please, aromatase inhibitor. Like what? Aromatase inhibitor like letrozole, as they reduce endometriosis-associated pain. Aromatase inhibitor may be prescribed in combination with oral contraceptives progestogen, GnRH agonist, or GnRH antagonist. What about surgical treatment? It is recommended to offer surgery as one of the options to reduce endometriosis-associated pain. When surgery is performed, clinician may consider excision instead of ablation of endometriosis to reduce endometriosis-associated pain. So excision is better than ablation. What about LUNA? What is the abbreviation of LUNA? Laparoscopic uterosacral nerve ablation is not beneficial as an additional procedure to conventional laparoscopic surgery for endometriosis, as it offers no additional benefit over surgery alone. So please don't do LUNA anymore. Laparoscopic uterosacral nerve ablation is not recommended. However, there is another operation called presacral neurectomy. It is beneficial for treatment of endometriosis associated midline pain as an adjunct to conventional laparoscopic surgery. But what is the problem here or disadvantage here? May be associated with risks of bleeding, also post-operative constipation, urinary urgency, and painless first stage of labor. And it needs skilled personnel to do the operation, so it is not an easy. Okay? When performing surgery in women with ovarian endometrioma, clinicians should perform cystectomy instead of what? Instead of drainage and coagulation. So, which is better, cystectomy or drainage and coagulation? Cystectomy is better. It reduces the recurrence of endometrioma and the endometriosis-associated pain. When performing surgery in women with ovarian endometrioma, clinician can consider both cystectomy and CO2 laser vaporization, as both techniques appear to have similar recurrence rate beyond the first year after surgery. Yearly post-surgical recurrence rate may be lower after cystectomy. Okay? When performing surgery for ovarian endometrioma, specific caution should be used to minimize ovarian damage, and this is very important. And there is a strong recommendation. Try to avoid any damage to the healthy ovarian tissue during cystectomy. Clinician can consider performing surgical removal of deep endometriosis, as it may reduce endometriosis-associated pain and improve quality of life. The GDG recommends that women with deep endometriosis are referred to center of expertise. Yes, it's important. The GDG recommends that patients undergoing surgery, particularly for deep endometriosis, are informed on potential risks, benefits, and long-term effect on quality of life. Okay, due to heterogeneity of patient population, surgical approach, preferences, and technique, the GDG decided not to make any conclusions or recommendation on the techniques to be applied for treatment of pain associated with deep endometriosis. Clinician can consider hysterectomy with or without removal of the ovaries, with removal of all visible endometriosis lesions in those women who no longer wish to conceive and failed to respond to more conservative treatments. Okay? And women should be informed that that hysterectomy will not necessarily cure the symptoms of the disease. So you may do hysterectomy, but the pain persists. You should know about this. When decision is made whether to remove the ovaries, the long-term consequences of early menopause and the possible need for hormone replacement therapy should be considered, especially if you did hysterectomy for oophorectomy for a woman of young age. Okay, so there will be need for hormone replacement therapy. Okay, the GDG recommend that one hysterectomy is performed, total hysterectomy is preferred. Yes, of course. There are currently no prognostic markers that can be used to select patients that would benefit from surgery. Such marker would need to be assessed prior to surgery and predict clinically meaningful improvement of pain symptoms. There are currently no prognostic markers that can be used to select patients that would benefit from surgery. Medical therapies as an adjunct to surgery. Medical therapies as an adjunct to surgery. Okay, what about that? It is not recommended to prescribe preoperative hormone treatment to improve the immediate outcome of surgery for pain in women with endometriosis. Okay, so don't prescribe preoperative hormone treatment before surgery for endometriosis. It is no more recommended. Okay. Okay, women may be offered post-operative hormone treatment. Okay, in the previous slide we talked about the pre-operative hormonal treatment. It is not recommended. But what about post-operative hormone treatment? Yes, women may be offered post-operative hormone treatment to improve the immediate outcome of surgery for pain in women with endometriosis, if not desiring immediate pregnancy. So please be careful about this point. We are talking here about relief of pain after the operation. You can give post-operative hormonal treatment for endometriosis, okay? But the woman is not desiring immediate pregnancy. But if she is desiring immediate pregnancy, she shouldn't give post-operative hormone. Okay? What about medical versus surgical treatment for endometriosis? The GTG recommend that clinician take assured decision-making approach and take individual preferences, side effects, individual efficacy, costs, and availability into consideration when choosing between hormone treatment and surgical treatment for endometriosis-associated pain. Okay, what about non-medical management strategies? Yes, but non-specific one, like improving the quality of life and psychological well-being. But as regard any specific non-medical intervention, it is not recommended. It is not recommended. Like what? Like Chinese medicine, electrotherapy, acupuncture, nutrition, physiotherapy, exercise, and psychological intervention. What about treatment of endometriosis associated infertility? We finished the treatment of endometriosis associated pain, and now we are talking about treatment of endometriosis associated infertility. In infertile women with endometriosis, clinicians shouldn't prescribe ovarian suppression treatment to improve fertility. So don't give the patient any drugs causing ovarian suppression if she is desiring fertility. Okay? Women seeking pregnancy shouldn't be prescribed post-operative hormone suppression with the sole purpose to enhance future pregnancy rate. Those women who cannot attempt to decide not to conceive immediately after surgery may be offered hormone therapy, as it doesn't negatively impact their fertility and improve the immediate outcome of surgery for pain. In infertile women with endometriosis, clinicians shouldn't prescribe taxophylline, other anti-inflammatory drugs, or letrozole outside ovulation induction to improve natural pregnancy rate. Operative laparoscopy could be offered as a treatment option for endometriosis-associated infertility in the revised American Society for Reproductive Medicine and Embryology Stage 1 and 2 endometriosis, as it improves the rate of ongoing pregnancy. Clinician may consider operative laparoscopy for the treatment of endometrioma-associated infertility as it may increase the chance for natural pregnancy. Although no data from comparative study exists, although no compelling evidence exists that operative laparoscopy for deep endometriosis improve fertility, operative laparoscopy may represent a treatment option in symptomatic patients wishing to conceive. The GDG recommends that the decision to perform surgery should be guided by the presence or absence of pain symptoms, patient age and preferences, history of previous surgery, presence of other fertility factor, ovarian reserve, and the estimated endometriosis fertility index. And this is very important, by the way, to take care about the endometriosis fertility index in your decision, and also the ovarian reserve. Women should be counseled of their chances of becoming pregnant after surgery. To identify patients that may benefit from ART after surgery, the endometriosis fertility index should be used as it is validated, reproducible, and cost effective. The result of other fertility investigations, such as the partner sperm analysis, should be taken into account. And by the way, the fertility index, including what item from the history, like the age of the patient, duration of fertility, and if it is primary or secondary, getting pregnant before or not, okay? And the other factors is the staging according to American Fertility Society of Reproductive Medicine and Embryology and the revised one, and also according to the result of laparoscopy as regard the tubal function and the anatomy, is it distorted or not, its relation to the ovary, both sides, right and the left, okay? Then you decide according to the score at the end. Each patient has special score. This is the fertility, the endometriosis fertility index, and it guides you in your decision according to treatment. Okay, let us go to the medically assisted reproduction. In infertile women with revived American Society of Reproductive Medicine stage 1 and 2 endometriosis, clinician may perform intrauterine insemination with ovarian stimulation instead of expectant management or IUI alone, as it increases pregnancy rates. So, stage 1 and 2 endometriosis, you can start induction of ovulation and the IUI. Although value of IUI, intrauterine insemination, in fertile women with stage 3 and 4 endometriosis with tubal patency is uncertain, the use of IUI with ovarian stimulation could be considered. ART can be performed for infertility associated with endometriosis, especially if tubal function is compromised, if there is male factor infertility, in case of low endometriosis fertility index, or if other treatment have failed. So, yes, ART has rule for many indications, as I said. Specific protocol for ART in women with endometriosis cannot be recommended. Okay? Both GnRH antagonist and the agonist protocol can be offered based on patients and the physician preferences, as no difference in pregnancy or live birth rate has been demonstrated. Women with endometriosis can be reassured regarding the safety of ART, since the recurrence rates are not increased compared to those women not undergoing ART. In women with endometrioma, clinician may use antibiotic prophylaxis at the time of oocyte retrieval, although the risk of ovarian abscess formation following follicle aspiration is low. So you can give prophylactic antibiotic before oocyte retrieval or at the time of oocyte retrieval to avoid infection. The extended administration of GnRH agonist prior to ART treatment to improve live birth rate and in infertile women with endometriosis is not recommended. Okay? As the benefit is uncertain. So don't give long protocol of GnRH agonists for long time as Zoladex 3.6 milligram intramuscular every month for 3 months before you start ART protocol. Okay? So it is not recommended as the benefit is uncertain. There is insufficient evidence to recommend the prolonged administration of COC or progestogen as a pre-treatment to ART to increase live birth rate. So you are not in need before ART protocol to give the patient for the few months COC or progestogen. No, there is no need because it is no proved value. Okay? Clinicians are not recommended to routinely perform surgery period to ART to improve live birth rate in women with stage 1 and 2 endometriosis, as the potential benefits are unclear. Clinicians are not recommended to routinely perform surgery for ovarian endometrioma period to ART to improve live birth rate, as the current evidence shows no benefit and the surgery is likely to have negative impact on ovarian reserve. Surgery for endometrioma period to ART can be considered to improve endometriosis associated pain or accessibility of follicles. So there is special indication for surgery before ART, either to improve endometriosis associated pain or to improve what? The accessibility of follicle. Okay? The decision to offer surgical excision of deep endometriosis lesions period to ART should be guided mainly by pain symptoms and patient preference, as its effectiveness on reproductive outcome is uncertain due to lack of randomized studies. What about non-medical management strategies? I said before, only changing the style of life, okay? But specific intervention like nutrition, Chinese, medication, electrotherapy, acupuncture, physiotherapy, exercise is not recommended. Impact of endometriosis on pregnancy and the pregnancy outcome. Patients shouldn't be advised to become pregnant with the sole purpose of treating endometriosis, as pregnancy doesn't always lead to improvement of symptoms or reduction of disease progression. And this is a strong recommendation. In the past, every gynecologist asked the lady, if you wanted to be pregnant, it's okay. It's very nice to be pregnant to manage endometriosis because it will be improved by the progestogen hormone of the pregnancy. But recently in the guidelines, not always lead to improvement of symptom or reduction of disease progression. Endometrioma may change in appearance during pregnancy. In case of finding an atypical endometrioma during ultrasound in pregnancy, it is recommended to refer the patient to center with appropriate expertise. What is the impact of endometriosis on pregnancy and the pregnancy outcome? This is very important. Complications related directly to pre-existing endometriosis lesion are rare, but probably underreported. Okay? Such complication may be related to what? To their decidualization, endometriotic patches, adhesion formation, stretching, and endometriosis-related chronic inflammation. What else? Although rare, they may represent life-threatening situation that may require surgical management. Clinicians should be aware that there may be an increased risk of first trimester miscarriage and ectopic pregnancy in women with endometriosis. Clinicians should be aware of endometriosis-associated complication in pregnancy, although these are rare, as these findings are based on low and moderate quality studies. These results should be interpreted with caution and currently don't warrant increased antenatal monitoring or dissuade women from becoming pregnant. What about endometrial recurrence? Prevention of recurrence of endometriosis. Okay, when surgery is indicated in women with an endometrioma, clinicians should perform ovarian cystectomy instead of drainage and electrocoagulation. And I said this before. For the secondary prevention of endometriosis-associated dysmenorrhea, dyspareunia, and the non-menstrual pelvic pain, however, the risk of reduced ovarian reserve should be taken into account. Clinicians should consider prescribing the post-operative use of levonorgestrel-releasing intrauterine system like Mirena or a combined hormonal contraceptive for at least 18 to 24 months for the secondary prevention of endometriosis-associated dysmenorrhea. After surgical management of ovarian endometrioma in women not immediately seeking conception, clinicians are recommended to offer long-term hormone treatment, like combined COC, for the secondary prevention of endometrioma and endometriosis associated related symptoms recurrence. For the prevention of recurrence of deep endometriosis and associated symptoms, long-term administration of post-operative hormone treatment can be considered. Clinician can perform ART in women with deep endometriosis as it doesn't seem to increase endometriosis recurrence per se. Any hormone treatment or surgery can be offered to treat recurring pain symptoms in women with endometriosis. What about endometriosis and the adolescents? This is a very important subject. How to diagnose? In adolescents, clinicians should take careful history to identify possible risk factors for endometriosis, such as positive family history, obstructive genital malformation, early menarche, or short menstrual cycle. Clinician may consider endometriosis in young women presenting with cyclic absenteeism from school or with use of oral contraceptive for treatment of dysmenorrhea. In adolescent, clinicians should take careful history and consider the following symptoms as suggestive of presence of endometriosis. Like what? Like chronic or acyclic pelvic pain, particularly combined with nausea, dysmenorrhea, dysuria, dyschezia, dyspareunia. Also cyclic pelvic pain. In absence of evidence for adolescents specifically, the recommendations for clinical examination in adults can be applied. The GDG recommends that before performing vaginal examination or rectal examination in adolescent, the acceptability should be discussed with the adolescent and her caregiver, taking into consideration the patient age and the cultural background. Sometimes some families, the adolescent girl is still virgin, and she never want to lose her virginity by BV examination. So don't do BV. You can do PR examination, of course, after taking consent from the patient and her family. Okay. Transvaginal ultrasound is recommended to be used in adolescents in whom it is appropriate, after her consent, of course, as it is effective in diagnosing ovarian endometriosis. If the transvaginal scan is not appropriate, patient refusing, she is virgin, she don't want to lose virginity, for example. So you can replace transvaginal ultrasound by transabdominal and MRI or transrectal scan. Serum biomarker like CA125 are not recommended for diagnosing or ruling out endometriosis in adolescents. Of course, it is not specific. In adolescents with suspected endometriosis where imaging is negative and the medical treatment with non-steroidal anti-inflammatory drugs or hormonal contraceptives have not been successful, diagnostic laparoscopy may be considered. If laparoscopy is performed, clinicians should consider taking biopsy to confirm diagnosis histologically, although negative histology doesn't entirely rule out the disease. In adolescents with severe dysmenorrhea or endometriosis-associated pain, clinicians should prescribe hormonal contraceptive or progestogen like the Unigest systemically or via levonorgestrel releasing intrauterine system as Mirena as first-line hormonal therapy because they may be effective and safe. However, it is important to note that some progestogen may decrease bone mineral density. Take care about this part. The GDG recommends clinicians consider non-steroidal anti-inflammatory drugs as treatment for endometriosis-associated pain in adolescents with endometriosis, especially if first-line hormone treatment is not an option. In adolescents with laparoscopic confirmed endometriosis and associated pain in whom hormonal contraceptive or progestogen therapy failed, clinician may consider prescribing GnRH agonists for up to 1 year, as they are effective and safe when combined with ADVAC therapy. The GDG recommend that in young women and adolescents, if GnRH agonist treatment is considered, should be used only after careful consideration and discussion of potential side effects and potential long-term health risks with a practitioner in secondary or tertiary care setting. In adolescents with endometriosis, clinician may consider surgical removal of endometriosis lesion to manage endometriosis-related symptoms. However, symptom recurrence rate may be considerable, especially when surgery is not followed by hormone treatment. So, it is advised to give post-operative hormonal therapy. The GDG recommends that if surgical treatment is indicated in adolescents with endometriosis, it should be performed laparoscopy by experienced surgeon, and if possible, complete laparoscopic removal of all present endometriosis should be performed. In adolescents with endometriosis, clinicians should consider post-operative hormone therapy, as I said before, as this may suppress recurrence of symptoms. What about fertility preservation? The GDG recommends that adolescents with endometrioma are informed of the potential detrimental effect of ovarian endometriosis and surgery on ovarian reserve and future fertility. If she has a ovarian endometrioma, for example, and you are going to do cystectomy, you may damage healthy ovarian tissue, you may affect the fertility of this girl later on, okay? So, this is very important subject. Fertility preservation option exists and the GDG recommends that adolescents are informed about them, although the true benefit, safety, and indication in adolescents with endometriosis remain unknown. What about endometriosis and the menopause? Clinicians should be aware that endometriosis can still be active, symptomatic after menopause. Okay, so if I ask you a question, can endometriosis happen in menopause? Yes, it can. Clinician may consider surgical treatment for postmenopausal women presenting with sign of endometriosis and or pain to enable histological confirmation of the diagnosis of endometriosis. The GDG recommends that clinicians acknowledge the uncertainty toward the risk of malignancy in postmenopausal women. If a pelvic mass is detected, the workup and the treatment should be performed according to the national oncology guidelines. For postmenopausal women with endometriosis-associated pain, clinician may consider aromatase inhibitor as a treatment option, especially if surgery is not feasible. So remember letrozole when you are talking about postmenopausal endometriosis. Clinician may consider combined menopausal hormone therapy for the treatment of postmenopausal symptoms in women, both after natural and surgical menopause with history of endometriosis. Clinicians should avoid prescribing estrogen-only regimen for the treatment of vasomotor symptoms in postmenopausal women with history of endometriosis, as this regimen may be associated with a higher risk of malignant transformation. The GDG recommends that clinicians continue to treat women with history of endometriosis after surgical menopause with combined estrogen-progesterone at least up to the age of natural menopause. Clinicians should be aware that women with endometriosis who have undergone an early bilateral salpingo-oophorectomy as a part of their treatment have an increased risk of diminished bone density, dementia, and cardiovascular disease. It is also important to note that women with endometriosis have an increased risk of cardiovascular disease irrespective of whether they have had an early surgical menopause. What about extrapelvic endometriosis guidelines? Clinicians should be aware of symptoms of extrapelvic endometriosis such as cyclical shoulder pain, cyclical spontaneous pneumothorax, cyclical cough, and the nodules which enlarge during menses. It is advisable to discuss diagnosis and the management of extrapelvic endometriosis in multidisciplinary team in center with sufficient expertise. For abdominal extrapelvic endometriosis, surgical removal is the preferred treatment when possible to relieve symptoms. Hormone treatment may also be an option when surgery is not possible or acceptable. For thoracic endometriosis, hormone treatment can be offered, but if surgery is indicated, it should be performed in multidisciplinary manner involving thoracic surgeon and or other relevant specialists. What about asymptomatic endometriosis? Is there any asymptomatic endometriosis? Yes, there is asymptomatic endometriosis. What to do with this asymptomatic endometriosis? Okay, the GDG recommends that clinicians should inform and counsel women about any incidental finding of endometriosis. Clinicians shouldn't routinely perform surgical excision or ablation for an incidental finding of asymptomatic endometriosis at the time of surgery. Clinicians shouldn't prescribe medical treatment in women with incidental finding of endometriosis. Routine ultrasound monitoring of asymptomatic endometriosis can be considered. Although, sorry, we shifted to another item right now, primary prevention of endometriosis. Okay? Although there is no direct evidence of benefit in preventing endometriosis in the future, women can be advised of aiming for a healthy lifestyle and diet with reduced alcohol intake and regular physical activity. The usefulness of hormonal contraceptive for the primary prevention of endometriosis is uncertain. Genetic testing in women with suspected or confirmed endometriosis should only be performed within a research setting. Endometriosis is not associated with significantly higher risk of cancer overall. We are now in endometriosis and the cancer. What do you know and what did the guidelines say? Endometriosis is not associated with significantly higher risk of cancer overall. Although endometriosis is associated with higher risk of ovarian, breast, and thyroid cancer in particular, the increase in absolute risk compared with women in general population is low. The GDG recommend that clinicians reassure women with endometriosis with regards to their cancer risk and address their concern to reduce the risk by recommending general cancer prevention measures like what? Like avoiding smoking, maintaining a healthy weight, exercising regularly, having a balanced diet with high intake of fruits and vegetables and low intakes of alcohol and using sun protection. And based on the limited literature and the controversial findings, there is little evidence that somatic mutation in patients with deep endometriosis may be predictive of development and or progression of ovarian cancer. Clinicians should reassure women with endometriosis about the risk of malignancy associated with the use of hormonal contraceptive. In women with endometriosis, clinicians shouldn't systematically perform cancer screening beyond the existing population-based cancer screening guidelines. Clinicians can consider cancer screening according to the local guidelines in individual patients that have additional risk factors like strong family history and specific germline mutation. There is epidemiological data, mostly on ovarian endometriosis, showing that complete excision of visible endometriosis may reduce the risk of ovarian cancer. The potential benefits should be weighted against the risks of surgery, like what? Like morbidity, pain, and ovarian reserve affection. This is the last slide. Thank you. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. This is my books published on Amazon, textbook of obstetrics, textbook of gynecology, contraception handbook, and the multiple choice question. You can go to the Amazon through this link. Also, you can find many other lectures on my YouTube link here and other scientific slides.